bullet everywhere, and nobody's getting no stray bullets. Nobody's getting hit by stray bullets. So at the end of the day, you are able to kill what you want to kill with minimal side effects. And with cancer, understanding cancer biology helps us to be able to do that much better. And when we are able to find out the type of cells that are there, we can develop specific drugs, innovative drugs, to be able to take care of such cells. And also, there's something we call profiling. Now, this is interesting. The police or the military guys understand this very well. There's something we call military intelligence. So when you look at an individual, you might not have met the individual before. So once you're able to profile the individual, you know this person is this height, has this mark on the face, looks this particular way, dresses this particular way. Even though you haven't met that person, because you have the information, the first time you're meeting that person, you're likely to identify the person. And say, okay, this is the profile of Mr. So-and-so that I saw earlier on, and this is how he looks. So definitely, this is Mr. So-and-so. And what does that mean? It means that if you're able to get the person's address, you're able to get the person's facial appearance, fingerprint, you can identify the person, you can look for the person, and you can arrest the person. That's what molecular profiling does. This time around, we are not using military intelligence. We are using what we call the pathological, or pathology rather, skills. And then we are able to profile the cancer, get all the markers. And with that, you can say, oh, this cancer has 10 markers. And out of the 10 markers, 2 of them can be targeted. So that means I can eat these cancer types with 2 targeted therapy. I can get better response with that. Instead of just, bringing the general treatment, and at the end of the day, there is no response. The cancer keeps growing. Unlike when you have targeted therapy, you're able to identify the target. You're able to profile the cancer, that you can have better outcome in that sense. So let's quickly look at personalized care. Innovations, advanced technologies in oncology they've been able to help us to personalize, care for individual patients who has cancer. How do I mean? Like I said earlier on, you can see 2 different women having the same breast cancer. The first thing is that they can even have the same type of breast cancer, but the 2 individual women, they are not the same. Number one may be married with children, the other one is not married. One may be coming from a family background that's previously they recorded breast cancer. One may be associated with genetic factor, one may not be. So they are not the same. We have to ensure that these individuals receive personalized care. And how do we go about that? We ensure that the treatment is tailored. It's as though you're just going to your, to your fashion designer, and he or she is able to design something that is tailor-made for you, fit for you. So you individualize the treatment. Oh, this woman is going to benefit from hormonal care. This will benefit from immunotherapy. This will not benefit from immunotherapy. Why do we need to talk about this? Some of these innovative drugs are quite expensive. So you don't want to be using the innovative drugs that runs into millions of naira per treatment for patients who may not benefit from it. So the first thing you want to do is to identify the cancer biology. Do we have the markers that you can target with immunotherapy? For example, the popular one, the PD-L1 marker. Okay, it's there in this colon cancer. It is not there in this colon cancer. It is there in this lung cancer. It's not there in this other woman who has lung cancer. So this other woman or this other man will benefit from immunotherapy. This will benefit from other forms of targeted therapy. So you personalize the care. There are individuals that you may also need to look into their family. How will this woman be able to cope with family care, with her work, with her business? So you don't want to give her treatment that will, stop her or hinder her from doing her treatment, her care or her work. Then there are many barriers in developing world that have made it practically impossible to have personalized care for patients. I published the paper about personalized medicine in oncology, and we looked at a number of barriers that will not allow individuals to have personalized care in developing world. But I must say this at this point: Nigeria is much better. Okay, there are so many barriers including cost, especially. You want to give an individual immunotherapy that will cost about 6 million, 7 million per treatment. You can't do that if the person cannot afford it or the insurance is not stepping in. That would be difficult. How about the skills? How about the equipment? How about the technical know-how? How about the professionals? You know, a lot of things, a lot of barriers in developing what that you find it difficult. How about the availability of the innovative drugs? For example, we don't manufacture such drugs in Nigeria. You have to import them. So how can we have access to these drugs? How easy? Then what is the cost like? So we need to look at that. But Nigeria is better. Why did I say it so? About 4 years ago, we used to have few radiotherapy machines, you know, in few places in Nigeria. And people would travel across the cities, across the state to be able to have access to this radiation therapy. But now things are much better. In Lagos alone, we have in good places. On the island, there is one. On the mainland, there is one. And as I'm talking to you, I'm glad to also say that Mikio has brought in a machine as well. So we're going to be helping patients to have radiation therapy with ease. And people can also travel, even from outside the country, to come and have their treatment. So in Nigeria, things are better. We have more comprehensive cancer centers. We have our first ever PET-CT scan in West Africa located in Lagos. That's Mikio Cancer Center. And people are traveling all over West Africa to have PET-CT scan done in Lagos. So things have improved so much. So let's look at diagnosis. How have innovations brought so much improvement to diagnosis? The first one, which we all know, is a digital consultation. That's teleconsultation and also result interpretations. I've worked in a place where there was no in-house radiologist. So what you do essentially is that you get the images, you upload the images, and then you have radiologists who are based in the UK, in the US, and other part of the world. And they are able to look at the images, give you a report in less than 30 minutes. Even if it is urgent, you can get it in 5 minutes, in 10 minutes. And that means that has been made possible because of innovations on digital platform. Then we can also have international multidisciplinary tumor board as a result of digital platform where you discuss a case across the nations. People from Australia, people from Canada, people from the US, UK, and other part of the world can discuss a case, and then you have what we call recommendations from the tumor board, which you can use to treat the patient in any part of the world. So innovations, technology has made that possible. Molecular profiling and testing, which I mentioned earlier on, so it's also due to innovation. We can search for so many markers. There is something we call next-gen sequencing. There is something we call liquid biopsy. So you can take blood, just small volume of blood or a drop of blood, and then look out for the presence of cancer cells and all the markers that are associated with the cancer cells. You can look at how many of the markers are targets that you can use. How many of them can you give immunotherapy, other form of targeted therapy, aside chemotherapy? The world is trying to move away from chemotherapy as much as possible. But I can say at this point that chemotherapy is still a mainstay in oncology care. Until we get to that point, we can push it aside. So then in terms of oncology, that's medical oncology treatment. Innovative drugs are now available. And the truth is that innovative drugs have changed the game in oncology outcome. I'm telling you, things are changing every day. Interestingly, we have this outcome where advanced rectal cancer, a particular immunotherapy drug called dostarlimab was given to a number of clients who had advanced rectal cancer. Advanced rectal cancer means the possibility of curing it is practically zero. So you can reduce it, but so far, the number, about 12 or 13 of them were noticed to experience what we call complete response. That means the whole cancer disappeared, and they were monitored for months, and the cancer didn't come back. And now in ASCO 2024, the same number has increased to about 42 who experienced, complete response. That means things are changing. There's another drug we call lutetium therapy in advanced prostate cancer that has gone all over the body. You can give lutetium therapy, and the prostate cancer can practically disappear from the body. So things are changing now, and there is a fact that we tell our client, once it is advanced, it is not curable. But that fact may be changed very soon as we keep innovating in the world of oncology. And then the purpose, that has also helped with reducing the side effect and also changed a lot of things, like I said. Now, dostarlimab was used in advanced, that's mismatch repair gene deficient patient with rectal cancer, and it was done at MSKCC. And the results so far, even during ASCO 24, has confirmed that about 42 of them have complete response, which is remarkable. I can tell you that. Then in terms of radiation therapy, so many things have happened. So many things have happened. I remember many years ago, radiation therapy, all you need is to just get X-ray film. We call it more or less like 1D to 2D treatment. X-ray film, then you use the X-ray film to put a mark on the patient, and then you blast with radiation. So that means that you're trying to target, let's say, prostate. But because you're trying to kill cancer cells in the prostate gland, don't forget that in front of the prostate, you have the bladder, at the back, you have the rectum. So, and then you have other structures around, you have the bones and the rest. So when you blast it like this, what you're saying is that, let me just kill the cancer. I don't mind how many of the normal tissues I can kill, as long as I can destroy the cancer. But things have changed now. So what we do what's called treatment planning system. That entails you having the images on the screen, and you can contour what you want to treat. Then isolate the particular target you want. And you are also able to see the dose of radiation that the target is going to get, and what we call the organ at risk. Organ at risk are the normal tissues that surround the target. So you can say, I want to treat prostate gland. My prostate gland is going to get about 70 gray eventually, but the bladder will get about 30, 20 something. Okay, it's still fine. The normal tissue tolerance for bladder is above 30, so I'm fine. Bladder is not going to have any major side effect. There will not be symptoms, as it were. So the same thing, you look at rectum. The same thing when you're treating patient with breast cancer, you look at where you want to treat the axillary level, the chest wall, and internal mammary nodes. Then you look at the lungs. Am I able to give the lung the dose that the lung can withstand? So we can see that on the screen before the patient starts treatment. So a lot of things have changed. And I'm so glad that, this time around, we have it in Nigeria. And there are other forms of modulations we do with radiation therapy as well. We do what we call the intensity modulation, the volume modulation. It means that you can modulate the dose that the target or the organ gets by considering or giving consideration to the volume or the intensity of the radiation or the volume of the organ you're looking at. So then there's something called gated technology. This is quite interesting. When you want to give patient radiation, you assume that the organ you're targeting is not moving. So what happens when the organ is moving? For example, when someone is breathing and you want to target the tumor in the lungs, the lung is not going to remain still. So that means when you're breathing in and out, something is happening. There's a movement. So the tumor is also moving. So we have gated technology that can work with that with the respiration. So as you breathe in and then it moves, and then the radiation is able to follow the movement. The radiation keeps its eyes on the tumor. So whether it's moving up or moving down, the radiation keeps eating the tumor. So that's a beautiful technology that's moving on. Then the same with movement regulation, where you are able to keep the patient still and patient is not able to move about so that you don't miss the target. Then innovations have brought speed and efficiency, into radiation therapy. For example, there's something we call the ethos technology. Artificial intelligence is used to power this. So you find out that the individual on the table while you're simulating. This is how we do when we want to treat radiation patient, we want to give radiation therapy to patient. The individual will come in. First of all, you acquire the images via a process we call the simulation. So CT simulation, sometimes we have MRI where we fuse to be able to get clearer images. So and then when we get the images, we are able to plan with the images as though the patient is there. So when the patient is ready for treatment, whatever plans that we would have put up on the images, what we'll use to take care of the patient during treatment. Now, it means the patient will come for simulation, then take a break, come back for treatment on different machines or different CT scan, as it were. But with Ethos technology, the patient can have everything on the same table. That means the speed, the efficiency, the outcome, you can achieve it on the same table, which is beautiful. And then we have stereotactic radiation therapy. We have the other ones also, like proton therapy, the flash therapy. You can also have that for radiation. Then I'll talk surgeries, just to list it. I'm not here to focus on surgery, but you can see we have less invasive surgical interventions when it comes to oncology care, laparoscopic, robotics, so many, and the interventional procedures are also used for palliative care. So let's look at the vaccine, which is the last thing I will talk about before show you the references and take the questions. So there are many vaccines now, or let me just say there are some vaccines that we use now to treat cancer. For example, there is the one we call the Sipuleucel T that we use in prostate cancer, and also there's the one we use for bladder cancer, BCG commonly. And we have the TVEC that is used in melanoma. So this will help us to personalize the patient care. For example, you can even isolate some cells from patient body, from patient serum, and then you can build technology around that and then put it back to reinforce the immune system of the patient to fight the cancer. So a lot of things happening, and there are many vaccines that are still in clinical trials. There are two of them that are in clinical trials, the one for pancreatic cancer and the one for the head and neck. So with all of these technology and innovations that we have seen so far and the ones that are currently being researched, I am very confident that in the next few years, oncology care is going to be greatly transformed. Thank you very much. These are the references.
We can do better. Can we do better? First, it keeps to the time. Can we do better? Another thing I noticed is that when he mentioned that radiation therapy in Nigeria now is now available, I thought we were going to shout and clap, but maybe because we don't know what it means. It means a lot. Let's clap now. Having radiation center 3 Nigeria is a lot. Back then, I know some people that would travel all the way because of radiotherapy abroad to come and have it, the cost of flight, the cost of treatment and likes. But now, there is hope for us, hope alive in Nigeria. Thank you so much for that wonderful presentation, sir. So, we take question and answer now. I know. I'll give room for 4 questions, 2 from this side, because we are still having the time, 2 from this side. So from this side, the 2, 1, 2. 1 and 2. Thank you. Okay. The ushers are on break today. They are just resuming. Okay.
Well done, sir. Good morning, everyone. The question I have here, you talk of vaccine therapy during your management plan. Do you mean that this vaccine therapy can be given before the onset of the cancer or during the management of the cancer? That's when you are going to give this vaccine therapy as one of the plan. Do you understand the question, sir? Okay. For more clarification, I said the question is the vaccine therapy. You mentioned radiation therapy, medical therapy, surgeries, and like that. Now, the vaccine therapy, are you going to give that vaccine before the onset of the cancer or during the management, the patient has already contacted or having the cancer?
Okay, I got that. Thank you. Should I answer that before the next? Or I take them together?
If you are comfortable, anyone, sir.
Okay, let me quickly answer that. When it comes to vaccines, they are in different categories. There is the one that is called preventable vaccines. That means you give them to prevent the cancer. But what I am focusing on is the vaccines that we use to treat cancer. For example, when we talk about the vaccine for human papilloma virus, that is to prevent cancer. You give it to the young boys and then the girls as well from the age of 8 years old. We have the recommendation for the doses. So, but when it comes to the treatment itself, you give the vaccine when the cancer has already occurred. For example, the BCG, BCG is a common thing that we all know, but it is given intravesically when a patient develops bladder cancer, especially after transurethral resection bladder tumor. So resection of bladder tumor, you can give that. For the one for prostate cancer, you give it when the individual has developed prostate cancer. Usually, we don't even start with vaccines. We give vaccines to individuals who have received other form of treatment and probably they had a relapse or there was no response. Then vaccine can come in. Vaccine has not been recommended as the first line at the moment. In fact, many researches are ongoing when it comes to vaccine therapy. So I don't know if that helps a lot or not.
Thank you.
Thank you.
Good morning, everyone. I appreciate your presentation, sir. Quite explanatory and makes it easier to sink into us. Thank you, sir. My question is, you mentioned 5 types of cancers. And the most aggressive one is virtually seen in Nigeria. Can we know what are the factors responsible for this? And which way can we prevent such from happening? Do you get my questions?
Yes, I did. Thank you very much. I mentioned different types of breast cancer to be specific. There are different types. And I also mentioned that from the research I did and the publication I made, you can check it out. In fact, it's in one of my references. You can Google and see. You see that the percentage, the proportion of triple negative breast cancer, which is known to be the most aggressive type of breast cancer, is more among the blacks. It's a well-known fact, and we found out that it is true even in Nigeria when we did the research. So the genetic factor can act as a background. The truth of the matter is some of these cancer occurrences cannot be prevented. Some can. We have many factors that are associated with cancer types. Some of them are preventable, some of them are not preventable. So what we do with preventable risk factor is to remove them. The ones that are not preventable, for example, cancers that are associated with age, you cannot stop the person from growing older. So what we need to do is to do regular checkup and detect it early. Then, or someone that has genetic factor, let's say BRCA gene. BRCA gene is well known to be associated with BRCA1, BRCA2, well known to be associated with breast cancer, ovarian cancer. So once that is identified with a great, percentage of penetrance, it in regular checkup. Okay. So is that enough? Okay. Thank you.
Hello, Dr. Adeniji. Thank you very much for the talk. There is a misbelief hovering around saying that cancer doesn't kill the patient, but the treatment does. Is there a way you can debunk that, please? Thank you.
Thank you very much for that. Well, we all know the truth that what kills the individual is the cancer, not the treatment. So they are saying the opposite. And I've seen this, individuals that come into consulting room and I'm there, the first thing they want to say, they have a lot of information that they are getting from the community, from these WhatsApp groups and the rest that are not true. The first thing they will tell you that, cancer feeds on sugar, so the first thing, cut off anything carbohydrate. I said, it is not even true scientifically. Even if you eat protein, the protein you're eating, when you take a lot of it, the body is satisfied with protein. It can convert it back to glucose in your body, glycogen storage. And then when you need glucose, it's broken down. So that doesn't even work. And also, if you don't eat balanced diet, the immune system will go down. The blood level will go down. Your strength will go down. You cannot even withstand the rigors of the treatment. So that doesn't work. And then the fact that they are saying that treatment kills, cancer doesn't kill. What they are trying to refer to is the side effects of chemotherapy. Side effect of chemotherapy can be managed. Some individuals have died from side effect of chemotherapy, but they are very, very minimal. That's why, of very few, we check the patient. We have criteria. A patient that is not strong enough, we don't give chemotherapy. And that's the reason chemotherapy should be administered by professionals, people that understand how to take care of the side effect, how to prevent the side effect. And there are many individuals who have gone through chemotherapy, and they are doing very well now. So if you leave cancer unattended to, it will grow and it will kill that person faster. And the way to attend to cancer is treatment. So that statement is not true. It is the opposite. Thank you.
Thank you so much for your presentation, sir. I think in my case, I have more some recommendations that the Oncology Society of Nigeria can look into. You hear, have you heard of Baba Aisha Herbal Medicine? They are everywhere. Everywhere they are there. They are tested and trusted. Now, I left it in the hotel. Have you seen the things they can treat? If your doctor say you have prostate cancer, come. If they say you have breast cancer, come. We give you something you drink one time, everything goes away. So you even find professors, after the doctor has told them, sorry, you've moved to stage 4, this, they will, for fit palliative care, they will move to Baba Aisha Herbal Medicine. And I was recently looking at America's classification of a level of prevention. In Nigeria, you agree with me, we have primary, secondary, tertiary, arranged as preventive, when you now have the disease and it's treatable, and when you have complications. In the US, primary is you are just educating. Secondary, the person may or may not have the disease. And even if the person has the disease, the person is not showing signs yet. It's tertiary that the person now has the disease. Like they've pushed their level of prevention to the point that they are working very hard. That is why in Nigeria, we define our breast cancer prevention as doing mastectomy. In the US, you do genetic mapping. And even when you're a teenager, your parents are able to know if this child, or you would be able to know if this child has the BRCA1, BRCA2, or has gene. And then you tell them, oh, at this age, do this, do that, prevent this, prevent that. We know Angelina Jolie, okay, she's an actress. She does not know how her great-grandmother died, but her grandmother left breast cancer. Her mother left breast cancer. What was she able to do with this information? Genetic mapping. She had the genes. Right now, she's alive. She's the first in a long line of female children in her family who will never have breast cancer because there's no breast to have the breast cancer on. Another thing is misinformation. I think he has addressed that. And yes, about the drugs. If you notice, most of our drugs in Nigeria are from India. The International Trade Organization has this generic and branding system. If we are unable to make cancer medications from scratch, why don't the researchers like you in pharmaco-oncology and in clinical oncology start making brands of chemotherapeutic drugs here in Nigeria? That way it becomes more affordable. And that way we're able to make things that maybe work better for us based on increasing and decreasing some substrates. I'm not in talking terms with cancer. My favorite cousin died from breast cancer. And she became a professor at 40 years. So you can understand. Nigeria does not have her anymore. Thank you so much.
Thank you. Let me quickly say a few things and then I can hand over the mic. Thank you for that contribution. I mean, very nice, very great. Concerning the regulation, we have regulatory bodies in Nigeria who are meant to do that. The Association of the Professional Oncologists, where I belong, that's ACON, Association of Radiation and Clinical Oncologists in Nigeria, can give recommendation to the regulatory bodies to be able to do that. We've seen a lot of all of this. The truth is the regulatory bodies also are fully aware of what is going on, and they're trying their best to ensure that they reduce that, to the barest minimum. And then when it comes to the to be able to confirm the BRCA gene in the person, we have labs that can do that now. Labs. Some of them try to do it within the country. Some of them, send it outside the country. And now we have criteria for doing such. And once we see that a patient qualifies for that, we do the BRCA gene and we can guide accordingly. And then you can tell the patient, okay, these are the recommendations, and he or she, makes that decision. Then as regards the manufacturing of drugs from the scratch, especially oncology drugs are not like the regular or everyday drug. So even many pharmaceutical companies are still trying to meet up with the regular everyday drug manufacturing, but none is into oncology manufacturing process at the moment. The first that's going to be on the list is Mikio. Praise, you understand, is Mikio. And then Mikio, in a way, has this capacity to introduce innovation. Mikio has always been like that. For example, the first diagnostic center to bring in the CT scan to make it commercially available, it was Mikio first, 1.5 Tesla MRI. In Nigeria, Mikio. The first PET CT scan in West Africa, Mikio. Now, the first company to manufacture oncology drug, we are already looking into that. It's going to be Mikio, because we need to be able to do that. That will be able to help us to cut, the cost that is associated with the middlemen. And then with that, we'll be able to save a lot of money. The reason people go to Indians to import drugs is because you have the cheapest brands there. If you go to Europe, you go to America, you're going to spend in dollars, and you're going to spend a lot of money. For example, you have immunotherapy coming from India, which is good. It's a brand, generic one. You pay about 1 point something million, 2 point something million. Then you go to developed country, and then they are asking you to come and pay 6 million, 7 million, 8 million for a particular brand because it is coming from the company, the innovative brand. So a lot of people cannot afford that. But imagine if we are able to manufacture the immunotherapy drugs in Nigeria. It means that one that goes for 1.5, let's assume it's generic. You can get it for less than $1 million. You can get it for about $500,000. That makes a whole lot of difference. It means you can bring more people to have the treatment. And then you can have more response when you treat cancer. So I think I would like to stop there in the interest of time.
Thank you very much, sir. Before you go, sir, I have 2 questions, but one has been answered. Why is it that our own is so aggressive? Well, everybody is asking questions based on patients. I didn't see anybody asking based on the carer. And over the time, I've managed some cancer patients and I've been involved in giving chemotherapy as well. And I discovered that most of these medication are so hazardous. Even some caregiver react to it badly. I've worked in a place that there's a specific set of people, nurse, that enter chemotherapy room because other people have to ask, are we looking into this? And to complement what Dr. Daniel said, that is there anything that we are doing locally to make our own production, one, to make it affordable, and two, to look at these reactions because most of them are coming out. What are we doing to focus on that, sir?
Okay, looking at the reaction of the drugs, the side effects are well known. That's why the professionals that handle such drugs, or the people that handle such drugs should be professionals who are used to it. So, for example, you don't go with some chemotherapy drugs home and give the carer to attend to if it is not the type that can be taken home. Otherwise, there will be issue. There are measures we put in place to be able to, mix the drugs, administer the drugs, and then before then we would have counseled appropriately. However, there are few chemotherapy drugs, tablets especially, that individuals can take home. And when they get home, they can have that. And I don't expect any carer to go and take the drug or to go and be exposing himself or herself to the one in powdered form. We don't even send that home except the regular drugs. Then concerning why the most aggressive breast cancer is found among the blacks, it is genetic. I believe it's on the background of genetic. A lot of things have been said as regards that, but nothing has been we have not been able to point out at a particular thing responsible for that. There are things that happen spontaneously. You just find out that, okay, in the US, you hardly find things like cervical cancer, why they give vaccines. That's understandable. In Nigeria, when you get to the US, number one, gynecological tumor, you're talking about maybe, you're talking about endometrial or something like that. But when you come to this part of the world, it's different. The epidemiology is not the same in different parts of the world. That's the reason we do the study, to know what's peculiar to each community and what should be done. So we just found that a triple negative is common among the black, is aggressive. And that's one of the reasons that the response were compared to developed world. If you have hormone receptor positive breast cancer, that woman will probably respond better when you give hormonal treatment in addition to chemotherapy or without chemotherapy. But imagine giving that to triple negative, even with the chemotherapy that is found, or even with immunotherapy. The tumor want to come back, or it doesn't want to respond to treatment. So that cannot be fully answered at the moment, but we just know that it's common among the blood. The reason, we are still trying to find out the major reason. There is a gene, but which gene? That is the question. We found out that people that have BRCA gene and they have triple negative breast cancer, when you add things like platinum-based chemotherapy or immunotherapy to their care, they respond better than just only chemotherapy. But how about the other people with that BRCA gene that have triple negative breast cancer? So a lot of things, and you see some patients with triple negative breast cancer, you give them simple chemotherapy, they respond very well. Some, even with tiny tumor at the early age, you give them the best shot, the tumor keeps growing. So there are many things that we are still trying to, to establish. That's where researches have to be on for as long as possible. Thank you.
Thank you very much. A round of applause. We do more, we can do more. Thank you so much for this presentation, sir. We really enjoyed it. That was so fantastic and so timely. Thank you, sir. You're welcome, sir. We all hear this thing. Everything in Nigeria is unknown. Everything is aggressive. Please, health giver, take care of yourself. There's a saying, I think one of our nurses week team say, nurse the nursing. Healthcare, please take care of your health. Thank you very much. We'll be